Well, it's wonderful to be here, really. I really thank you for the invitation. It's not only wonderful because this is a fascinating city, but also I really enjoy talking about Bechet syndrome here because I know that you have a lot of patients, and I know you have very interesting patients with all kinds of vascular and other important types of involvement. And I really enjoy learning from you also about Bechet syndrome. How do I go forward with this? The other one, okay. Okay. So as you all know, this is a multisystem variable vessel vasculitis that involves all sizes of arteries and veins. And it's common around the ancient Silk Route, a famous trade route. All symptoms are recurrent. This is the most important thing about Bechet syndrome, I think. It follows a course with relapses and recurrences. And the disease is usually more active during the early years. So patients usually start with oral ulcers during their childhood, and the other skin manifestations such as genital ulcers, nodular and papulopustular lesions usually start after adolescence, and these are followed by uveitis and venous thrombosis that usually start during the early 20s, and the other gastrointestinal, nervous system, and arterial lesions usually start with the age of 30 during the 4th decade of life. And usually after the age of 40, Bechet syndrome starts to fade away. And we know that there is more severe disease, although the men to women ratio is almost similar, maybe just a little bit more common in men. Men have a more severe disease course, and the prognosis is worse, especially if the disease onset is before the age of 25. So this is a multi-system disease, really. It shows a very heterogeneous presentation. About half of the patients have organ involvement, what we call eye involvement, CNS involvement, vascular or gastrointestinal involvement, whereas the other half of the patients only have mucocutaneous lesions. And oral ulcers are the most common of these lesions. There are really no laboratory tests or imaging or histology findings that are specific for Bechet syndrome that help the diagnosis. And we really make the diagnosis by putting together all of these signs and symptoms. But before going to those symptoms, I just want to talk a bit about why we call this a Bechet syndrome. You may realize that in your program it says Bechet's disease, but some of us, including myself, prefer to call this a syndrome. Because we and others have shown that there are clusters in disease presentation of Bechet syndrome. So this is the study that we had done some years ago. One of the clusters is the mucocutaneous cluster with oral ulcers, genital ulcers, and nodular lesions. There's another cluster that I will be shortly talking about, the papulopustular lesion and arthritis cluster. In our study, uveitis tended alone by itself, but in other studies it was shown that it is associated with nervous system involvement, and that is probably in our series because there were few patients with nervous system involvement. So uveitis and central nervous system seems to go together. And also there's this vascular cluster of superficial thrombophlebitis, deep vein thrombophlebitis, and also arterial involvement in some of the series. So there are these patients with subgroups of symptom clusters that show differences in demographic features, the disease course, and also in drug response. For example, tocilizumab is known to work well for uveitis and nervous system involvement. On the other hand, it was shown to cause flares of mucocutaneous involvement in some of the patients. So all of these really makes us think whether these clusters may have different pathogenetic features. So let's go a bit more detailed on some of these symptoms. Oral ulcers are the most frequent manifestation of Bechet syndrome, and they can be very painful and disabling, and they're usually the first manifestation that can precede the diagnosis by 7.5 years. They can be minor, that is the most common form, but they can also be major, leaving scars, and also they could be herpetiform ulcers. Bechet syndrome is not the most frequent cause of ulcers anywhere in the world. Even in places where Bechet syndrome prevalence is quite high, as in Turkey, it is only one of the minor causes. When you see a patient with acute oral ulcers, the probability of having Bechet syndrome is very low in that patient. If there's a patient with chronic oral ulcers, meaning ulcers that have been going on for more than 6 weeks, that is not Bechet syndrome. You should have to think about something else. It is the recurrent oral ulcers ulcers that makes us suspect Bechet syndrome. And among these also, Bechet syndrome is not a common cause. Most of these patients are idiopathic. There are nutritional deficiencies. There are other rheumatologic diseases such as lupus, FAPA syndrome, reactive arthritis, also other inflammatory conditions such as inflammatory bowel disease. So although the specificity, the sensitivity is very high, the specificity is quite low for oral ulcers. What it helps is, it actually helps us rule out other conditions. So if a patient presents with features resembling Bechet syndrome but does not have oral ulcers, then I think it's time to think of other diseases. Genital ulcers are a bit more specific. They are seen in about 80 to 90% of the patients in different series. They have a less frequent recurrence rate. Oral ulcers can occur like 10 ulcers a month, whereas genital ulcers are seen only a couple of times during a year. To differentiate it from other causes of genital ulcers, the localization helps. In women, genital ulcers are usually on the major labia, and in men, they are usually on the scrotum. It's very infrequent to see the ulcers by ourselves, as rheumatologists, because patients with genital ulcers usually go to a dermatologist or a gynecologist. But if we are lucky, we can see these scars. Large ulcers, those larger than 1 centimeter, do leave scars, and seeing those may be diagnostic for patients with Bechet syndrome. However, there are still other conditions in patients who have oral and genital ulcers. Other than Bechet syndrome, they can have inflammatory bowel diseases, Magic syndrome, reactive arthritis, certain infections such as herpes and CMV infections, Sweet syndrome, erythema multiforme, Bell's diseases, cyclic neutropenia, lymphoma. All of these conditions can cause genital ulcers and oral ulcers. If you see the genital ulcer yourself, that is quite helpful. As you see here, when you ask the patient, they do say that they have genital ulcers, but when you see these lesions, they are quite discriminative. In Crohn's disease, they are usually linear ulcers, and in reactive arthritis, they are usually on the penis, which is almost never involved in Bechet syndrome. Erythema nodosum-like lesions usually occur on the lower extremities, and they usually heal with hyperpigmented scars. The diagnostic challenge here is to differentiate it from superficial thrombophlebitis. That is also quite common in patients with Bechet syndrome. As you see here, if the thrombophlebitis is in a short segment of the vein, it is clinically indistinguishable from erythema nodosum. An ultrasound may help here. With erythema nodosum-like lesions, you see a hyperechoic lesion just beneath the skin. On the other hand, with superficial thrombophlebitis, you expect to see a hypoechoic lesion. And if you're able to biopsy, you see septal and lobular paniculitis in erythema nodosum-like lesions, whereas, of course, there's intraluminal thrombus with superficial thrombophlebitis. Papulopustular lesions are very nonspecific, really. They can be in two forms. They can be acneiform lesions, which are indistinguishable from acne vulgaris, especially in young patients. They are usually on the face and trunk, and they really do not help the diagnosis. Folliculitis, the inflammation of the hair follicle, may be a bit more helpful. It usually occurs on the arms and legs, and it can also present in patients presenting at an older age. One interesting point is that these papulopustular lesions are more common in Bechet syndrome patients with arthritis. Arthritis occurs in around half of the patients. It's usually a mono or oligoarthritis with large effusions in the knees and the ankles of the patients. It usually lasts 1 to 3 weeks. It is quite bothersome with quite frequent recurrences. However, it's not an erosive or damaging type of arthritis. I was just mentioning this association of papulopustular lesions and arthritis. This, I think, is very interesting. We had, apart from the cluster study that I had already shown, we had previously shown that papulopustular lesions are more common in Bechet syndrome patients with arthritis. And in the past, it was thought that these lesions are sterile pustules. And we also showed some time ago, these are actually infected with Staphylococcus aureus, Streptococci, and Provetola that you are familiar with from the RA microbiota studies. So these are infected, and they cause arthritis, and they are also associated with enthesopathy. We later showed that patients with acne and arthritis had enthesopathy scores quite similar to patients with ankylosing spondylitis, whereas Bechet syndrome patients without arthritis did not have these scores. They were just similar to healthy controls and RA patients. So this makes this cluster a bit similar to spondylarthropathies. And when we looked at the sacroiliitis and the HLA-B27 in these patients, however, they were not related to sacroiliitis, and they were usually not HLA-B27 positive. They were not different from healthy controls. So the pathology phenomena is, I think, very interesting and an important feature of Bechet syndrome that is also quite specific. This is a hyperreactivity to minor trauma that we use to diagnose patients. What we do is we make a needle prick with a 20 gauge needle. We actually make 6 pricks, 3 on each arm, forearm, and we call the patient back 48 to 72 hours later to see whether there is a papule or a pustule formation at the injection site. And as I said, this is quite specific for Bechet syndrome, but the frequency has been decreasing over the years. In our clinic, pathology positivity was 82% in 1980, whereas it dropped to 46% in our study in 1993, and to 23% in the more recent study. And this is thought to be due to the improvement in hygiene in our patients, because it was also shown that surgical cleaning decreases the pathology rate in patients. And the pathology phenomena does not always occur in skin or with the reaction. As you can see here, for example, after dental treatments, patients may present with several oral ulcers, or with subcutaneous injections with anakinra or interferon alpha. We have seen these skin reactions. Also, there may be difficulty in wound healing in these patients. And you see here an angiogram, a peripheral aneurysm in a patient who underwent catheterization. So pathology phenomena is an important feature of Bechet syndrome patients that you really need to be careful about when performing a procedure. So these are the mucocutaneous and joint lesions in patients with Bechet syndrome. And although they are not really damaging the patient, they are not organ or life-threatening, they cause an important impairment in the quality of life of our patients. So they really need to be treated properly, as we will be talking in the afternoon. Coming to major organ involvement, the most common one is eye involvement. Uveitis is seen in around 50% of the patients, around 70% of men who have a disease onset below 25 years. And it's usually present at onset of the disease or during the first 2-3 years of the disease. It's rare to see uveitis development after 5 years after the diagnosis of Bechet syndrome. And this can be in the form of an anterior uveitis, intermediate, posterior, or pan-uveitis. But in most of the patients, this is a bilateral, non-granulomatous pan-uveitis. It's only about 10 to 15% of the patients who have isolated anterior uveitis. And if there is hypopyon, which is a severe form of anterior uveitis, it is almost always accompanied by severe retinal vasculitis in patients with Bechet syndrome. And if these are not treated, loss of useful vision is apparent in about half of the patients. So this is an important type of uveitis. In the differential diagnosis, of course, you have to exclude infectious causes, especially bacterial, viral, fungal, and parasitic infections, especially tuberculosis and toxoplasmosis in Turkey. I don't know what are the rates here, but it may differ, of course, around the world. However, these infectious causes are very important to exclude, because otherwise you will be treating these patients with immune suppressives, which will obviously will be detrimental in patients with infectious uveitis. And among the non-infectious causes, there are several other diseases that cause non-infectious uveitis, but most of them are isolated anterior uveitis, such as spondyloarthropathies, inflammatory bowel disease, juvenile idiopathic arthritis. All of these conditions cause only anterior uveitis. When there is posterior or panuveitis, Bechet syndrome is an important cause, along with sarcoidosis, Vogt-Koyanagi-Haradas disease, and lymphoma. So it's important to remember that even when the patient already has a diagnosis of Bechet syndrome, it's important to exclude infections and lymphoma in these patients. We as rheumatologists are very frequently referred patients with uveitis. So when you see a patient with uveitis, of course, the first thing is to exclude infections with serology, microscopic examination and cultures, and also search for systemic disease. Of course, for Bechet's, you will be seeking for oral and genital ulcers, skin lesions, arthritis, and all of the things that we've been talking about, but also for abdominal pain, diarrhea, and gastrointestinal bleeding that would suggest an inflammatory bowel disease, inflammatory back pain, enthesitis, and HLA-B27 positivity for spondyloarthritis, and autoimmune serology if there are other findings suggesting a connective tissue disease, and mediastinal and other lymph nodes, and granulomatous lesions elsewhere for sarcoidosis. I will be talking a bit more about vascular involvement. Vascular involvement can involve both the venous and the arterial sites of all sizes. For venous involvement, what we see is usually a deep vein thrombosis that can be together with superficial thrombophlebitis, and less frequently hepatic vein thrombosis, vena cava superior and inferior thrombosis, intracardiac thrombosis, and cerebral sinus thrombosis. And this is an inflammatory thrombosis, so there is no hypercoagulability in our patients with Bechet syndrome. The cause of the thrombosis is inflammation of the vein wall. For arterial involvement, what we see most commonly is pulmonary artery aneurysms, but also there can be peripheral and aortic aneurysms in patients, and also we can see patients with pulmonary artery thrombosis and extrapulmonary artery thrombosis. And there are also other rare things such as central retinal vein thrombosis in eye involvement and thrombosis in mesenteric artery branches in gastrointestinal system involvement. When we look at the frequency and time course of these vascular events, as I said, the most frequent involvement is the deep vein thrombosis of lower extremities. And when we look at the time course, this figure shows the first, second, third, and fourth vascular events in patients, the breakdown of the causes of the vascular events. As you see, deep vein thrombosis is the most frequent cause in the first event, but with the preceding events, more central venous thrombosis and arterial involvement, both pulmonary and peripheral artery involvement, become more frequent. And also there are clusters within this vascular cluster. Superficial thrombophlebitis and deep vein thrombosis go together. So when a patient starts to have frequent superficial thrombophlebitis, this may be a sign of an upcoming deep vein thrombosis. Also, Budd-Chiari syndrome goes together with inferior vena cava thrombosis. Superior and inferior vena cava thrombosis may be associated, and cerebral sinus thrombosis may be more common in patients with pulmonary artery involvement. Also remember that vascular involvement may be the initial manifestation in patients with Bechet syndrome. When we looked at our 330 patients who did not fulfill the international study group criteria for Bechet's when they presented, we saw that about half of these patients fulfilled criteria over time. And among these 27, almost 10% of the patients had vascular involvement as the presenting manifestation. So if a patient, especially a male patient, is having recurrent venous thrombosis that are not explainable by any other cause, any hypercoagulability or any prothrombotic factors, you should always consider Bechet syndrome in areas where it is prevalent. The venous thrombosis, as I said, is an inflammatory thrombosis. It's a very sticky thrombosis that usually do not cause any pulmonary emboli. The relapses are very frequent. There were 2 retrospective series. One of them is the French series and our previous series. The 5-year relapse rates were 37% and 38% in these studies. When we started looking prospectively in these patients, we saw that this was much more higher. In 12 months, despite treatment, 41% of the patients presented with relapse. And the most important predictor of relapses was recanalization in these patients. And the consequence of relapses are these venous ulcers, post-thrombotic syndrome with leg ulcers that are very difficult to heal in these patients. So it's important to stop recurrences in patients with deep vein thrombosis. This is a novel finding. In the last few years, there have been studies with MRI and also ultrasound showing that the vein wall is thickened in Bechet syndrome patients. I think this is a sign of the inflammation of the venous wall. It was also suggested that this can be used as a diagnostic tool for Bechet syndrome patients, but I think this is quite premature at the moment. And for arterial involvement, pulmonary artery aneurysms are rare. It's seen in about 1 to 3% of patients with Bechet syndrome, but they are the most lethal complication of Bechet syndrome. Also, patients with pulmonary artery thrombosis can be seen frequently associated with aneurysms, but it's important to remember that hemoptysis is not always due to pulmonary artery aneurysms in patients with pulmonary artery thrombosis. They can occur due to bronchial artery enlargement that happens secondary to the pulmonary artery thrombosis in these patients. And this is an important consequence of this, maybe pulmonary hypertension, just similar to chronic thromboembolic pulmonary hypertension. And you see here some of the endarterectomy material that was obtained from these patients, but I'm not really sure this is a very good therapeutic option, especially if the patient is still active in Bechet syndrome due to the pathology phenomena. And also you can see peripheral artery aneurysms, which present as pulsatile masses, and abdominal aorta aneurysms, which usually present with back pain, abdominal discomfort, and hydronephrosis. And when you image these patients, you are able to see the inflamed aorta, which is encased in a thick fibrotic tissue. For CNS involvement, the frequency is around 4%. In cross-sectional studies, it goes up to 10% with long-term follow-up. And there are 2 distinct forms of CNS involvement. The first one is the parenchymal disease. That is the most common one. It happens in 80% of the patients with CNS involvement, and it has a poor prognosis. On MRI, you usually see a heterogeneous contrast-enhancing lesion in the brainstem, the encephalon, pons, or bulbus. CSF shows increased number of cells, mainly neutrophils, also some elevation in protein levels, and rarely oligoclonal bands. About 1/3 of the patients have a progressive course from onset, and about 50% of the patients are disabled at 10 years. So this is important for patients. Mortality rate is 11%. This is a rare but severe manifestation of Bechet syndrome. And the remaining 20% of the patients have dural sinus thrombosis, which is actually a manifestation of vascular involvement in Bechet syndrome. These patients usually present with headache, papilledema, and 6 nerve palsy. And in addition to MRI, MR venography is helpful in the diagnosis of these patients. And remember that peripheral neuropathy is very rare in patients with Bechet syndrome. For gastrointestinal involvement, this is the type of involvement that shows the highest geographic variation across countries. And in our part of the world, this is really rare. It's about 1 to 3% of the patients. On the other hand, in the Far East and also in the US, the frequency of gastrointestinal involvement goes up to 30%. Patients usually present with abdominal pain and diarrhea, but also sometimes they may be asymptomatic. So whenever we see a patient with Bechet syndrome with unexplained acute phase response, we perform a colonoscopy and look for GI lesions. These are usually large, deep, single ulcers that most commonly occur in the terminal ileum. And due to their depth and largeness, they can cause perforation and bleeding in up to 1/3 of the cases. And in the differential diagnosis, you should be, of course, considering Crohn's disease together with tuberculosis and NSAID-associated ulcers. In the diagnostic evaluation of gastrointestinal involvement, this can be quite straightforward. If the patient has typical GI ulcers and already has a diagnosis of Bechet syndrome, as long as you exclude non-steroidal anti-inflammatory drug ulcers and infections, it's safe to say that this patient has GI involvement of Bechet syndrome. On the other hand, when GI manifestations precede other systemic manifestations of Bechet syndrome, this can be difficult because Crohn's disease and Bechet syndrome has many shared lesions, the oral ulcers, genital ulcers, arthritis, uveitis, which is mostly anterior uveitis in Crohn's disease, nodular lesions. These can all present in both of these conditions. So the differential diagnosis may be quite difficult. Endoscopy may help if the lesions are oral or round ulcers, which shows Bechet syndrome, or they are longitudinal, snake-like, or star-shaped ulcers, which show Crohn's disease. But there are several cases which show irregular ulcers or geographic ulcers, and in this case, the localization and the distribution of the ulcers help. If the patient has focal single or focal multiple ulcers, you should be thinking more about Bechet syndrome, whereas if the patient has segmental diffuse ulcers, then it highly suggests Crohn's disease. And for histology, the mucosal biopsies that you get during colonoscopy usually are not helpful in the differential diagnosis. You just see inflammation. On the other hand, if the patient undergoes surgery and you have a surgical sample, then you would see a necrotizing vasculitis, a lymphocytic necrotizing vasculitis with fresh thrombi in patients with Bechet syndrome, whereas in Crohn's disease patients, you would be seeing cryptitis, crypt abscesses, and a non-caseating granuloma in lamina propria, which would help the diagnosis. So as I said, there are no specific laboratory tests, imaging, or histology results. We just put together the signs and symptoms to diagnose these patients. There have been several criteria sets for the diagnosis of Bechet syndrome. On the left, you see the international study group criteria, where you have to have recurrent oral ulcers plus 2 other criteria among recurrent genital ulcers, ocular involvement, skin lesions, and pathology phenomena. And on the other hand, there is the newer ICBD criteria, where oral ulcers, genital ulcers, and ocular involvement gets a score of 2, each of them. And vascular involvement, CNS involvement, positive pathology phenomena, and skin lesions get a point of 1. And you need to have at least 3 points to get a diagnosis of Bechet syndrome. So both of these criteria have their down points. For international study group criteria, you need to have oral ulcers, which is not present in 2% of the patients, as I told, and also less frequent but severe manifestations such as gastrointestinal involvement, nervous system, and vascular involvement are missing from these criteria. So if a patient presents to you with a typical pulmonary artery aneurysm and oral ulcers, you still cannot diagnose this patient as Bechet syndrome according to the criteria. And with the ICBD criteria, the sensitivity is obviously higher. However, it loses a lot from its specificity. And this is especially problematic in areas where the prevalence of Bechet syndrome is low. And so what are the most discriminative findings for Bechet syndrome, for a diagnosis of Bechet syndrome? First of all, oral ulcers help. As I said, the absence of oral ulcers strongly suggests another diagnosis in a patient. The presence of eye involvement helps only if you have a very experienced ophthalmologist to work with. There was a study where ophthalmologists came together and looked at retrospective images of patients with uveitis, and they said that there are some discriminatory findings, and ophthalmologists have a good specificity in diagnosing these patients, but really you have to have a good ophthalmologist for this.
Sorry,
genital
Professor,
ulcers,
5 minutes.
Okay, thank you very much. And genital ulcers are quite common in these patients, and if you see the lesion itself, that would help the diagnosis. For major vascular involvement, pulmonary artery aneurysm are quite diagnostic for Bechet syndrome patients, and for parenchymal neurologic disease, if you have an MRI that shows brainstem atrophy, isolated brainstem atrophy, together with lesions extending from the brainstem to the basal ganglia, this is quite diagnostic of Bechet syndrome. Thank you very much.